topic of neonatal diabetes, which is quite distinct from the other forms of diabetes, especially the ones we've discussed like the type 1 diabetes. So what are the key things that we have to consider when you have a neonate with diabetes, Dhani?
So the most important is the age criteria. When you have children less than 6 months of age, is more likely to be neonatal. Even the 6 to 12 month age, if GAD is negative, one must think of neonatal diabetes.
So one, of course, is the age of presentation, which becomes important. How is it different from a normal type 1 diabetes?
Important thing to consider that each student can also have a concomitant exocrine pancreatic insufficiency if it is
true.
Secondly, these may have mutation responding to oral medications and may not require insulin.
So generally, they will have some genetic forms of diabetes which would require a different type of treatment, and that is something which is important from that regards. Can you have autoimmune diabetes in the first 6 months of life? So when you talked about 6 months as being a criteria that below 6 months you should think of neonatal, but can you have autoimmune diabetes in children who are less than 6 months of age?
Some form of that, like IPEX can be
So you can have some other forms of diabetes which can have that sort of a thing, which is the IPEX-like syndrome, where you can have those features in that regards. The other big challenge which is there in regards to is that when you have many neonates, they are sick. They have a lot of infections, they have other scenarios, and they may have transient hyperglycemia. So how would you really decide whether this is really a transient hyperglycemia or a true neonatal diabetes?
When the hyperglycemia causes, like they are requiring insulin for more than 3 years or 7 years in the admission, and if there are like they are having a vasopressin use or other drugs.
So if there are no significant cause of transient one, if your HbA1c is definitely high, if you have a persistent insulin requirement, which is a major criteria, you have to consider treatment. So now the 3 key questions which you have to answer in a child with suspected neonatal diabetes is it really neonatal diabetes? Is it transient versus permanent, and what's the cause? So this is important because of a number of conditions will actually cause transient hyperglycemia, which may not be diabetes. So what will tell you that this is more likely to be an actual neonatal diabetes? If the birth weight is less, which means that the insulin deficiency antedated the scenario. Failure to thrive, of course, will be a big sign. Dehydration, epilepsy and developmental delay may point towards a potassium ATP channel defect, particularly the Dent syndrome. And of course, you will have other features like polyuria and ketoacidosis. Any child with onset before 6 months of age and 6 to 12 months of age with negative antibody would require a genetic workup. Very importantly, HbA1c tends to be unreliable in this age group. When I say unreliable, is the problem of sensitivity or specificity?
Sensitivity.
So if you have a low HbA1c, can it still be neonatal diabetes? If you have high HbA1c, it definitely confirms that. So what you need to understand is that because of the increased RBC turnover, because of the fetal hemoglobin, your HbA1c will be falsely low in neonates. So if your HbA1c is high, so if your potassium is low in somebody who is on an angiotensin receptor blocker with hypertension, you say, okay, this is very, very likely to be hyperaldosteronism. Same. Here, your HbA1c is high despite the neonatal period where it should have been lower. It means it is definitely a case of neonatal diabetes. But if the level is low, you cannot exclude it. That becomes important. So onset in the first 6 months, rarely 6 to 12 months, sugar levels are more than 200, and very importantly, as Vibha said, more than 3 days of insulin requirement is what should think of neonatal diabetes. You have to rule out other infections. Sometimes you're giving too much fluid. Transient can be caused because of that. Steroids, pressors, and beta agonists may all cause that. If your HbA1c is more than 6.5, you are pretty sure that this is neonatal diabetes. Now, transient versus permanent. So if you have an earlier presentation without ketoacidosis, with a lower weight and a higher sugar, you are more likely to be transient, especially if there is omphalocele umbilical hernia. Finally, about the cause. So here you will have to go for family history. If there is consanguinity, think of Walcott-Rallison and glucokinase deficiency. Diabetes in family, especially milder form, think of GCK defect. Skeletal abnormalities will suggest Walcott Rallison. Eczema and diarrhea will indicate the possibility of IPEX syndrome. Look for malabsorption, neurological features, and rickets-like features. Where are you looking at rickets? Will be the one. So if you have skeletal dysplasia, think of Walcott Rallison. If there are neurological features, think of a potassium ATP or rarely a neuro D1 defect. Liver dysfunction in Walcott Rallison. Hearing defect in Wolfram syndrome, which we haven't mentioned here, and Rogers syndrome, which will come more in terms of the next class, which will be on monogenic diabetes. Immune defects in IPEX, eye abnormality in Wolfram syndrome, and PAC6, cardiac defect as we discussed, GATA4 and 6. Now, investigations, pancreatic status imaging is not very good. So as I said, fecal elastase is a better measure. Insulin status rarely required in somebody where you're thinking of resistance. Think of insulin and C-peptide. And for etiology, most of us will now go for a complete next generation sequencing to identify that. Antibodies are not going to help. Very importantly, get a blood sugar in both the parents along with ketones and immune status to get the diagnosis. So Dhwani, day 3-year-old boy with prematurity, blood sugar is 200, birth weight is 1400, 32 weeks, no dehydration, labeled as neonatal diabetes. Do you agree?
No, we have to rule out stress hyperglycemia before.
So you have to think of some other causes. So very importantly, whether the GIR was high, whether there is some steroids, some vasopressors, so all that factors. So if they was on a high dose, the sugars became normal on lowering. So Alapan, 14-day-old girl, premature with respiratory distress, blood sugar is 270, weight is 1800, ketone is negative. What do you think? There is no steroid going on, no other issues. Hospital.
Eventual challenge. Blood sugar is high, and weight is on the lower side. So there is
no other exposure. You have to think of that, but there is steroid and beta agonist. So this will basically go more towards a transient hyperglycemia, secondary response. Day 15 girl with failure to thrive, birth weight of 1700 grams at term. So there is a significant SGA, dehydrated, emaciated appearance, blood sugar of 320, HbA1c is 5.6. So it is most likely a neonatal diabetes. Now, HbA1c may not be very significant. She had persistent hyperglycemia and insulin was started. Now, 8-day-old girl, birth weight of 1800 grams, current weight is 1720, thick looking. Blood sugar is 425, insulin was started. Now, there is omphalocele 6q24. So, what do you think will be the likelihood progress from here? Yeah.
So, again, compared to the previous cases, this is HDA, very high sugars in comparison to the previous cases. Omphalocele again points to methylation defect. These will, by 3 months, 4 months, we'll be able to stop insulin and finally sulfonylurea and adolescence.
So I think if we continue with the previous case, which we discussed, a sick looking girl who was found to have, was not affording genetic study. Now, later on, she improved over time. So what do you think happened in this case? Transient diabetes. Now, on follow-up, she was started on insulin. There was weight gain and clinical improvement. Requirement reduced, stopped at 12 weeks. But 9 months developed hypoglycemia. So why was this hypoglycemia developing? But why would they cause hypoglycemia? The suppressive effect, as Vibha said, of the ZAC, HYMA, and the PLA-GLA1, those regions goes off, and that's why those become more hyperactive for some time. So they develop hypoglycemia with hyperinsulinism, which improved. Now, after 12 years, presented with polyuria and blood sugar of 240, HbA1c is 8.4, started on insulin. Do you agree? This is the same girl.
So this again the patient relapses because of the development of this
Pubertal insulin resistance. Yeah. Yeah.
So should we start with insulin but later at 10?
So we should strongly think of a sulfonylurea treatment here, and ABCC8 defect was found in this regard and sulfonylurea was started. Now, stable on glibenclamide, planned for marriage, concern about offspring risk. So this is more in context with a 6q24 defect. What will be the chance of this person transmitting the girl?
Mother's genes are silent, so from mother
Yeah.
to offspring, children may not be affected, but we will have to be one of the subsequent
Yes.
generation.
So it will be mainly from subsequently from there. 2-month-old boy with failure to thrive, birth weight was 2500, now 2800, has hepatomegaly, myopathy and weakness, very high sugars, HbA1c is high on glargine and lispro. What do you think?
All failure is present and associated features like hepatomegaly, myopathy, and weakness is there. Diabetes, neonatal diabetes.
Yeah.
So better to start with insulin
And
and
go for a genetic testing. Suppose somebody cannot afford genetic testing, will you start sulfonylurea there?
you can check for the response to something.
Yeah, but it is not recommended. So off the label, you may consider that, but that's not what is routinely recommended. So better to get a genetic testing. Now the panels have come down, the cost has come down, so we should consider getting them definitely. And it for the KCNJ11 defect. On follow-up, glibenclamide 0.2 milligram per kg per day, increased to 1.2, sugars improved off insulin, developed developmental delay and hypotonia. It could be dead or it could be because of bad control earlier, but this is something you need to be aware that often we say, okay, it was because of his sugars which were high, but this could be because of the neurological involvement. The Dent syndrome, as we discussed, is there. It tends to improve once your potassium ATP channel gets recruited. So it is also going to improve in the muscle and the neurons over that. 1-month-old boy with failure to thrive, birth weight 2200, now 2300, blood sugar is 350, ketone is negative, normal faces, no hepatomegaly, parents had mild diabetes for which no treatment is being done. So what do you think? Yeah. Yes, so as you discussed, this could be a GCK deficiency which is there, and targeted panel showed a GCK defect. 10-month-old girl with polyuria, birth weight was 3400, blood sugar is 320, HbA1c is 10.2, no dysmorphism, no syndromic features. What do you think? This could be type 1, type 2, or neonatal MODY, whatever. So 6 to 12 months, as you said, you want to do an autoimmune workup, which is their GAD is negative. So now, so genetic study showed an insulin defect. So the presentation is delayed because of the second hit model, which is there. 12-month-old girl with failure to thrive, birth weight of 2500 grams, blood sugar of 360, ketone of 0.3, family history of consanguinity, and this is what we found on the X-ray. Distal phalanges are very, very small, and there's a tapering, yeah. So we should think of Walker-Trallison syndrome as a possibility, and they will require insulin for long. You have to keep a close watch as far as their liver function is concerned. 2-month-old boy with failure to thrive, blood sugar 320 with skin infections, diarrhea, GAD positivity. So is this type 1? So it's too early also. There are other manifestations you should think of. IPEX-like syndrome. So immune defects.